Okay, Melissa, thanks. Do you want to go to the first slide? So first of all, I'd like to thank everybody for attending. I can see we've got 49 people at the moment attending, which is just wonderful. But I particularly want to thank the panelists for giving up their time. So what we're going to do today is I'm going to just give a brief introduction about the registry, which in a sense is the part of the reason why we're here. And then I'm going to hand over to a galaxy of stars who are speaking today. We've got Basile Tessier-Cloutier from Memorial Sloan Kettering, who will soon be joining us at McGill as a staff pathologist, and the doyen, I think, of gynecology pathologist Glenn McCluggage from Northern Ireland, from whom all of us have learned so much over the years. Then followed by Joe Pressey, who's probably treated more people with small cell cancer than anyone else I know, and followed by my colleague and long-standing friend, who's also a real expert in small cell and other rare ovarian tumors, Amit Oza from Princess Margaret Hospital. And finally, back to McGill with Sidong Huang, who's going to tell us some really exciting ways in which we can use novel technologies to find new therapies for this disease. So, Melissa, let's move on to the first slide. So, the registry and biobank I want to tell you a bit about, because it's an important way to gather new data to try to understand and defeat this disease. So it was created just recently, really through the encouragement of Myron Peterson, who's really one of the leading supporters of our work, and other people we shall come on to later. The Eve Appeal helped us with some funding, and more recently the Department of Defense. So the idea is to collect information in biological samples, and each piece of information will help to improve our knowledge. So the participants, it really it's a collaboration between the healthcare personnel and the relatives, because we can't get all the information just from one source. People who unfortunately have died, we're hoping their relatives will help us, so that will, even if someone has passed away, we'll be able to gather information which will help other people. And anybody, in fact, with a variant in the gene that causes this disease, which is SMARCA4, even if they don't actually have small cell cancer, we're interested to collect their data, because that will also tell us quite a lot. So the idea is a questionnaire, which is a little bit detailed, but it's important to gather all this kind of information, as you can see here, contact, straightforward stuff, but also health status, pregnancy history, blood work, imaging, what kind of treatment you had. This is where the oncologist will be helpful. What treatment did you have? We'll be able to collect important information on what kind of treatments work better and which ones don't. What type of testing you had, what genes were found, what were the results? Do you have a family history of any other cancers, any other relevant disorders? And how are you doing at the moment, and how are things going? And there'll be a few other questions. So that's really which Melissa's in charge of. So I encourage anyone who has not yet been part of the registry to please contact Melissa. So far, it's a rare disease, as you know, but we're doing pretty well. We've got some consents going. We've got some participants, as you can see here, and with the help of people in the registry, we'll be able to collect samples. It's a slow process to collect tissue. Obviously, we have to get permission, we have to contact the hospital, and so on. So again, your support for this would be much appreciated. We've been able to reach out beyond the USA and Canada to the UK, Germany, as you can see, even Slovenia and Ireland. So we've got quite a nice reach now, and we hope to make this a worldwide effort. So the team at McGill, myself, Sid, Melissa, you just met, Leora, who's on mat leave, but is a key member of the SMARCA4 analysis group, Nancy Hamel, who's my long-standing lab manager, and Celine, who's joined us as essentially the lab person for this project. So it's a small team, but we're all dedicated to trying to do better with small cell cancer of the ovary. So I just want to thank, first of all, the Department of Defense who funded this project, and the people who sort of started it off really were the Small Cell Cancer Foundation, the Katie Opera Research Fund, and particularly the Eve Appeal in the UK, who actually gave us a startup funds really to get this thing off the ground, without which we would not have got the Department of Defense grant, and of course the Research Institute at McGill University who are hosting this project. So this is what the landing page looks like when you log on. And this is how you contact us. And of course, Melissa will pass this on to you as soon as possible if you're interested in taking this further. So just briefly, as an introduction to the rest of the presentation, what is ovarian cancer? Well, ovarian cancer is broadly split into these groups. So you first have epithelial ovarian cancer, which is the fifth most common and most fatal woman's cancer. And you often think of this as high-grade serous cancer of the ovary, but there are other types. And then the next type, which is much rarer, is a type of non-epithelial tumor, either a sex-cord stromal tumor or a germ cell tumor, which are sort of different to the epithelial types, but also different to small cell cancer, which falls into the miscellaneous group, and with the variable ages of onset. And they're really a sort of ragbag of different diagnoses. And it's in this group that small cell cancer of the ovary falls. So it's the most common and differentiated ovarian cancer in people under 40. The average age of diagnosis is only 24 years. There's maybe 500 cases now in the literature, but it's obviously very rare. It's, as I say, it's really still classified as miscellaneous ovarian tumor, though I think Glenn may comment that it's now going to get sort of coming out on its own as its own entity. It's no longer really miscellaneous. But as you will hear from Glenn, it can be difficult to diagnose, and it's important to have expert pathological input. And as you'll hear from both Dr. Pressey and Dr. Oza, we really need better treatments because it's an aggressive, unusually aggressive tumor with a very early age of onset, which makes it really unique amongst cancers. I don't think there's another cancer quite like this one of any type. So I think my final slide is just to show you, just to introduce Basile's talk, which is just to show you this is what the SMARCA4 protein looks like. It's got a funny name, it's SWE/SNF, and it really doesn't matter why it's called that. It's a long history. It was discovered actually in yeast, so that's why it's got this funny, not very sort of memorable name, this SWE/SNF sort of nomenclature. But it's a very large protein, as you can see here, with 1,600 amino acids. So that means it's got a lot of structure there. And as you can see here, the first three mutations we ever found, actually, when we were doing this work in 2014 with Leora, were these three variants that hit the ATPase domain. And that's an important structure, which I think Basile will pick up on. So I'm going to stop here, and we're now going to continue with Basile Tessier-Cloutier from Memorial Sloan Kettering.
All right. Well, thank you very much, Dr. Foulkes. Yes, I'll just say some words on the SWE/SNF complex, of which the SMARCA4 protein is part of. You can see on the left here of the figure, the SWE/SNF complex is actually represented in green, and you see it interacting with some DNA, which is the black strands, and some DNA organizers, which are those beige cylinders. And the complex here, the SWE/SNF complex, is very important in loosening up the DNA to allow the protein production. And to do that, to loosen up the DNA, the SWE/SNF complex will get rid of the organizers. And you can think of those DNA organizers, the cylinder here, as the reel that maybe some of you may have used to help with the earphone wires. In this case, you know, the wire of the earphone would be the DNA that's nicely coiled around the organizer. However, if you were to, let's say, get rid of all the organizers within the DNA at the same time, it would be, you know, really bad if you're trying to listen to music, but it's also very bad for the cell. So in that way, the role of the SWE/SNF complex is really to be a conductor. It will very specifically say to some areas of the DNA to loosen up and allow protein production while keeping other areas more quiet to keep some organization to everything. So it will tell, it will tell the violins to go louder on one end, tell the trumpet to go quieter. And that's really key to keep organization and allow the cell to develop in its final form. But to accomplish that, the Swiss-Nif complex needs interaction between many subunits that you can see on the right here. However, there really are 3 of them that are crucial for the functioning of the complex. If they are broken, then the Swiss-Nif complex will not be able to do its function as a conductor. And those 3, genes or proteins are SMARCA4 that we see in small cell hypercalcemic type, but also SMARCB1 and ARID1B that occur in other tumor types. Now, what if this complex is altered or broken, like I discussed? We'll see on the next one. The image here on the left is showing a tumor that has normal function of the Swiss-Nif complex. So maybe you can tell it's on the very left image, it's starting to make some structure. It's trying to actually make some glands here. And that's because, the Swiss-Nif complex is still able to be normal in that tumor. And we can prove that by looking at some special brown stain. And on the same side, you can see the tumor cells are all colored in brown. And that is because the Swiss-Nif complex here is functioning normally. However, when it's broken, either because of a mutation in SMARCA4, like in the small cell hypercalcemic type, or SMARCB1 and ARID1B in other tumor types, the tumor really loses any sense of making structures. It becomes chaotic and becomes really a soup of cells that are extremely disorganized. When we use, again, the same special brown stains in these tumors, we can show actually that the Swiss-Nif complex is broken, because now instead of being brown, it's completely, the brown stain is not present in the tumor cells. That means that this tumor in particular, it was not able to, did not have a functioning Swiss-Nif complex, and as a result, there is no conductor to help it develop differently. And I think that's mostly what I have to say for this complex. But I'll let Dr. Glenn McCluggage go further about the diagnostic component of this.
Thanks, Basile. That's wonderful. So Glenn McCluggage, as I was saying, is really one of the great experts on the diagnosis of this tumor. So maybe Glenn, you can take this on to the next level. I think you have to unmute, Glenn.
Oh, sorry, Will. Yes, thanks, Will, for the introduction. And as you probably know, I'm a histopathologist who specializes in gynecological pathology. So ultimately, I'm going to be the person who'll be diagnosing these rare tumors. Melissa, can you just move forward, please? And one more. So these are histological images of 2 different ovarian tumors. And now you can see that they're slightly different colors, but that's just due to the different staining. But the point I want to make is that looking down the microscope to a pathologist, these 2 tumors basically look identical. And one is a hypercalcemic small cell carcinoma and one is not. Melissa, can you move forward, please? And you can see here, this is a SMARCA4 immunohistochemical staining. Basile and Will have already mentioned that this gene is mutated in almost all of these tumors. and this results in loss of staining. So you can see here the tumor on the left is negative for this marker, proving or helping to prove that this is a hypercalcemic small cell carcinoma. And the tumor on the right, the stain, is actually retained, helping to prove this is not a hypercalcemic small cell carcinoma. Melissa, can you go forward? So what I want to say is that hypercalcemic small cell carcinoma really is an extremely rare ovarian malignancy. I've been working as a pathologist in Northern Ireland for about 30 years, and I see these cases through my referral practice from other regions. But in Northern Ireland, I can tell you that in the last 30 years, it's a small place with a population of about 2 million people, that I've only ever diagnosed 2 hypercalcemic small cell carcinomas in all of those 30 years. So this really shows how rare this tumor is, and this means actually an individual pathologist will not see one of these tumors in his or her working lifetime. So really, I also would make the point that I'm pretty sure in years gone by, these tumors were misdiagnosed. They were probably overdiagnosed because we didn't have this useful immunohistochemical marker to help make the diagnosis. So this is an algorithm we have suggested along with Will. We have published this when we're diagnosing one of these rare tumors. And I think the most important thing is at the top is that to have the tumor reviewed by a specialist gynecological pathologist and the diagnosis confirmed. And really, I would say this always necessitates this SMARCA4 immunohistochemical staining, and you should really doubt the diagnosis of SMARCA4 is retained. There are a small percentage of cases, maybe in the region of 5%, where SMARCA4 will be retained, but you should really doubt the diagnosis of the SMARCA4 is retained. Once the diagnosis is confirmed, sorry, could you just go back, Melissa? I think we recommend that all patients should be counseled for germline SMARCA4 testing because of the incidence of germline mutation. Now, most of these tumors, the mutation will be somatic and not germline, but there are, a not inconsiderable number of cases, and Will may know better than me, but it could be in the region of 20% where there actually will be a germline SMARCA4 mutation. In the case of a germline mutation, if only one ovary has been removed, basically the surgeon really, these cases should all be managed in specialist centers, but there is a risk of a tumor occurring in the contralateral ovary, so probably that should be removed. And in the case of a germline mutation, of course, there is the possibility to test family members for the mutation. And we actually have seen, and Will may want to comment on this, SMARCA4 mutation carriers, young females who have elected to go undergo prophylactic oophorectomy, which obviously is a big decision in somebody so young. And we'll go forward to my last slide, Melissa. The last thing I want to mention is that this tumor was described many years ago by a very famous gynecological pathologist, Robert Scully, and he gave this the name small cell carcinoma of the ovary of hypercalcemic type, which is a very kind of easily remembered name. But in many ways, it's a misnomer because the cells are not always small. Carcinoma, we usually mean, is an epithelial neoplasm, and really we think this is not an epithelial neoplasm. And only about 2/3, which I think is actually an overestimate, but certainly not all of these patients have serum hypercalcemia. And I actually think the name small cell carcinoma of hypercalcemic type can result in some confusion for oncologists because, of course, there is another tumor called small cell carcinoma, which occurs within the ovary, which is actually a quite different tumor, a neuroendocrine tumor, but this can actually cause confusion to clinicians. So I think the way we are possibly moving is these tumors, these SMARCA4 deficient malignancies, which are just like hypercalcemic ovarian small cell carcinoma, can actually rarely occur in many organs. And many of these are actually likely the same tumor arising within different organs. So we may be moving towards a more generic names such as SMARCA4 deficient ovarian malignancy, because similar tumors are found at other sites. I think that's all I want to say. Will.
Thanks, Glenn. That's a wonderful summary of a complex topic, and it naturally takes us on to, okay, you've made a diagnosis, you've spoken to the pathologist, you're sure it's a small cell cancer. How are you going to treat it? So let's hear from Joseph Pressey from Cincinnati, who, as I say, has perhaps treated more people than most, with his update on the standard of care of treatment for this disease.
Yeah, thank you, Will. It's a pleasure to be here today. So I'm a pediatric and young adult oncologist at Cincinnati Children's Hospital. And as you can see at the bottom of the slide, we have a large children's hospital, but we have a dedicated young adult oncology program, which has been very advantageous in developing our small cell carcinoma of the ovary program here. So I think, as Will had mentioned, we do have a very broad experience with this tumor. I think the first patient we took care of was back in 2006. So that's obviously well before we knew about SMARCA4. And so we were relying on pathologists to make a good diagnosis. Actually, we've been able to go back retrospectively and find that even the early patients I took care of actually had either SMARCA4 and actually one case of SMARCA1 mutation. And so it's an honor to take care of all these girls and young women that we have met over the years. So I joined the team at Cincinnati in 2014, and since coming here, I've had the pleasure of working with a fantastic group of physicians who have developed a really intense interest in small cell carcinoma of the ovary. And so I've got the pictures of everybody here because they're a very important part of what we do. Chris Dandoy's my bone marrow transplanter, and he's heavily involved in these patients, and everybody who comes here to Cincinnati is under his care as well. Roshni Das Gupta is one of our cancer surgeons, and she is our primary surgeon for the small cell population, and is very involved in HIPEC therapy that we'll talk a little bit more about as well. Sarah Sabo is my dedicated pathologist. She's also reviewed a lot of tumor samples from patients around the country and outside of the US as well, and takes a big clinical interest in these patients as well. So it's a fantastic resource to have here to confirm the diagnosis. And we don't think there's much harm in taking a second look at tumors, even if they're coming from outside institutions. If they haven't experienced with it, it's always good to have a second set of eyes. Luke Pater is one of our radiation oncologists, and is a big part of what we do. And Tara Strike is a gynecologist who's very involved in fertility counseling for fertility preservation, also hormonal replacement, which becomes a big issue, obviously, by the end of therapy. So we have a very broad experience with small cell population. We've treated patients from 13 months of age to 38 years, and we've consulted on patients that were actually even younger than that and older than that. Our approach I would describe as a pediatrics-inspired approach, and so the idea is that we're taking lessons that have been learned from malignant rhabdoid tumors that obviously overlap tremendously biologically. And so that's really given us hints as to which chemotherapy agents are most active, but also from desmoplastic small round cell tumor, DSRCT, which is a rare sarcoma that has an EWS fusion, but often arises in the abdomen and spreads in a way that's very similar to small cell carcinoma of the ovary, with peritoneal metastases and sometimes beyond the abdomen and pelvis. And so clinically, it has a lot of behaviors that are overlapping with small cell. I think the other issue is what I would describe as a pediatrics or young adult inspired supportive care as well. Because the therapy that I'm about to talk about, it can be fairly toxic, and it's very important to support these girls and young women very intensively throughout therapy. So we can go to the next slide. And so as you can see at the bottom here, this is our schema for how we treat patients with small cell carcinoma of the ovary. We use the 6-drug regimen BPC-BAE. Kind of a mouthful, but that's the best. I don't have a more snappy way of saying that. But we deliver 6 cycles of this therapy. And along the way, it's very important to collect hematopoietic stem cells early. So bone marrow stem cells, we believe, should be collected after cycle 1 or cycle 2, before the bone marrow becomes too exhausted with subsequent cycles of chemotherapy, with the idea that we believe that all patients, regardless of age or stage, should have consolidation with high-dose chemotherapy with stem cell transplant after the conventional chemotherapy is completed. One unique aspect to what we're doing is that we routinely do a second look operation after cycle 4 or cycle 5. So Dr. Dasgupta takes our patients to the operating room at that point and does a thorough exploration from the pelvis all the way up to the diaphragm, sampling any tissue that may be suspicious or resecting any residual nodules at that point. And we find that there's a fair amount of discrepancy between what we're seeing radiologically and what she sees intraoperatively. And so we think the second look operation is giving us a lot of insight in terms of how somebody's responding to chemotherapy. And then very importantly, getting those samples to Dr. Sabo in the pathology lab so she can evaluate things more closely and give us a sense of how much viable tissue may be left. Ideally, we hope to find 0 and see 100% necrosis, but in many patients, there is residual tumor, even in settings where the radiological response is complete. At the time of second look operation, we are also offering HIPEC therapy, which is heated intraperitoneal chemotherapy. And so we deliver cisplatin, which is one of our systemic chemotherapy agents as well, directly into the abdomen at that point. It's heated and it's instilled for 90 minutes and then aspirated out. We are recommending this for our patients with stage 3 or stage 4 disease. And I'll talk a little bit more about that in a minute. Once the 6 cycles of chemotherapy are completed and somebody's responding and moving along as we hope they will, they go on to bone marrow transplant, or what's really better described as high doses of chemotherapy, and then bone marrow cells are given to help rescue the body from the toxicity of the chemotherapy. We use a preparative regimen that includes busulfan, melphalan, and biotepa. Although when we interact with other institutions around the country or internationally, we think it's most important that the local institutions use a prep regimen that they are familiar with and have experience with. And so the specific regimen is probably less important. In some settings, we also offer therapy at the very end of therapy, but that depends on whether or not they have residual disease and how much residual disease they have at the time of the second look operation. I think the key here is that we strongly recommend that patients who are newly diagnosed to seek out centers where there's experience and comfort delivering the therapy that potentially could be associated with a fair amount of toxicity, and also where there is a true commitment and willingness to provide the supportive care that's necessary to make sure that our patients stay well nourished, well hydrated, that infections are being monitored for very carefully, and that there is a plan to get the patients into the emergency room quickly if they have fevers. Because we really need to support them very cautiously during this to get them through this and get them on with their lives. And so that would be one very important point to make today. Quickly, we're also very interested in investigational aspects of small cell carcinoma ovary. We want to learn more about HIPEC therapy. And so in our hands, it has been very feasible and safe. And we have found that there's little evidence that they are absorbing the chemotherapy into their bloodstream. So it really does seem to be staying localized within the peritoneal cavity within the abdomen. But we're going to learn more about that with more pharmacokinetic studies, a little bit more sophisticated than some of the work that's been done in the past. We're also interested in learning how to deliver radiotherapy better. It can be fairly toxic, especially with conventional radiotherapy. And so we have the luxury of having a proton beam radiotherapy facility here at Cincinnati Children's. And one modality we're very interested in exploring is flash proton beam, where the therapy is theorized to be more effective but less toxic. And so that is something we're working on in terms of delivering radiation to the entire abdomen. Another aspect of our investigation is Dr. Saba is very interested in the specimens that we're acquiring at the time of the second look operation. What can we learn from it? What can we learn from those patients who are responding effectively to chemo and those who maybe are having an inadequate or incomplete response? Also, how can we use this information to maybe tailor therapy beyond the second look operation? Are there additional agents or more targeted agents that we can use to tailor therapy and make it more personalized and more precision-based? Couple more issues. I'm also working with Dr. Somak Roy, who's a molecular pathologist here, and with some support from Maren Peterson. We're doing some methylomic profiling of tumors and also working on biomarker development here, and obviously trying to learn more about the biology of these tumors as well. And a final point would be that this is a tumor that I would describe as a classic adolescent and young adult oncology diagnosis. And so we recognize that patients between 15 and 39 years of age that we define as the AYA range have very unique aspects to their care in terms of very unique tumor biology, host biology, and obviously a lot of unique psychosocial stressors that we're trying to learn more about. And so we have the luxury, again, of having a dedicated AYA program here, all housed within the children's hospital, and it's given us a great opportunity to provide the best care possible. So that's mostly what I just wanted to go over today. But again, I just want to express what an honor it is to take care of all these girls and young women and be involved in their care and trying to give them the best chance possible to beat this. Thank you.
Thank you so much, Dr. Pressey. That's a really wonderful overview of what is the standard therapy now. So I think just from a slightly different perspective, I'd like to ask Amit Oza from I would say Canada's leading cancer hospital, which is Princess Margaret Cancer Centre in Toronto, to give us his take on treatment of this rare tumor.
So thank you very much, and thank you very much for asking me to participate on this panel. It really is an honor to be on this panel with everybody else. So I'm at Princess Margaret Hospital. I'm a medical oncologist, and we have a sort of very large multidisciplinary team that actually looks after patients with all types of gynecologic and ovarian cancers. We're also very integrated in terms of trying to understand how we can improve on treatments for gynecologic cancers, particularly working with clinical trials and trying to see if we can actually improve treatments with immunotherapies as well as targeted agents, understanding the biology of the disease. In terms of small cell hypercalcemic tumors, these are incredibly rare tumors, and because they're so rare, it's actually very hard to find good evidence-based approaches based on clinical trials. And this is one of the things that we're sort of trying to work with. Just following on from Joe's point in terms of actually having to have a very strong young adolescent program, I think that this is also a very important area that we need to sort of emphasize in terms of looking after patients with small cell hypercalcemic tumors. And we work with an AYA program, which is a bridge between Princess Margaret Hospital and Hospital for Sick Children in Toronto. I mentioned that one of the sort of approaches that with most cancer treatments that actually looks to integrating new treatments and improving the standard of care for treatments is to actually look at clinical trials. And this is where there have been sort of important sort of challenges in very, very rare tumor types. One of the approaches that we're looking at is to really try and see if we can actually integrate understanding biology from every patient that we see, and particularly patients with rare cancers. And we currently have a biomolecular profiling program called Venus, which really looks at many of the rare tumor types that we see, where patients are actually enrolled in the program. And with the original tissue that was perhaps taken at the time of surgery or a biopsy, we do detailed molecular profiling on every single patient, which looks at full somatic DNA profiling, as well as looking at immune profiling and germline profiling as well. And sequentially over a period of time, we're also looking at collecting blood from patients so that we can actually look at circulating DNA, again, with a view to trying to see if we can understand how the tumor changes over time. If we could just go to the next slide. In terms of trying to sort of really see how we can improve on treatments, one of the approaches that we're taking for extremely rare tumor types, including small cell hypercalcemic ovarian tumors, is to really have a deep dive into each individual patient. So really understand, what does the tumor molecular profiling and the biology tell us? What can we identify from this profiling as well as the pathology? Look at the evidence-based approaches that have been tried and where does the science point to? And this is where working with Will and Sid and others is extremely important. And we have a program that we've set up which basically individualizes a clinical trial around an individual patient. So this is an N of 1 clinical trial approach with a platform study that we have created so that each patient becomes a clinical trial, but they are then able to access treatments that may perhaps otherwise not be available in the setting of clinical trials, including novel immunotherapies and targeted approaches. That program also allows us to continue to follow up a patient as they go through treatment and look at minimal residual disease, so that if we can access blood, then we can look for circulating DNA to really try and identify, if we can identify sort of very, very early signs of fragments of DNA present in the blood that may perhaps allow us to intervene in a more realistic manner with immunotherapy as we go along. And again, there are some interesting approaches that are actually coming for small cell hypercalcemic tumors that are integrating immunotherapy at a much earlier stage, almost in an adjuvant fashion, that we need to sort of learn from and embed within our treatment policies. And if you go to the next slide. The one other sort of setting that we also sort of conduct as a group, and this is essentially a team exercise, is something called complex diva rounds, where we again, every 2 weeks, we'll have incredibly rare tumor types where we discuss the individualized data from a patient in terms of the clinical and the imaging data that has been gathered, but also put that in context of the latest literature and the assessment that we've done in terms of the genomic and molecular profile, and develop an individualized treatment plan in these rare tumor types. And I think that that is working well as a sort of team exercise in terms of how best to bring novel treatments to patients. So with that, Will, over to you again.
Yeah, thank you so much, Amit, for that really interesting summary, and pointing out how we need to integrate the genomics with the pathology, with the, as you say, N of 1 trials, which I think is for a disease like this is really the only way to go. We're never going to have randomized control trials that will be large enough to answer the questions fast enough for the people who need to know. But then when it comes to new therapies, we need to look outside the box. And this is where my colleague and friend Sidong Huang from McGill is really been pushing the envelope. So Sid, why don't you finish up with where you're taking things in the lab?
All right. Well, thank you, Will. And it's a great honor to be here to present some of the work we're doing in my lab. And as you know, we are trying to uncover new effective treatment options for school patients. And this has been challenging before we knew what caused this disease. Until 2014, where Will and among others discovered that SMARCA4 mutation infects the cause of the disease. And this allows us to design experiments where we can screen in an unbiased approach, that we either use a library containing genetic tools that can modify and inhibit gene function one by one across all the gene and cells, or the existing drugs that can suppress gene function for a subset of genes. And by using those libraries, we can identify which genes, when suppressed, can selectively target the cancer cell, kill the cancer cells that harbor SMARCA4 mutation, but not normal cells. And this is because this new addition, if you will, these targets are dependent on by this SMARCA4 deficient cancer cells. That's not the case for normal cells because SMARCA4 is intact. So such target obviously will be a desired treatment options because it will not target normal cells and thus will have less side effect. So this approach has been working very well. Just give one example from the past. When I was a postdoc at work we have done that had led to a FDA-approved treatment options for BRAF mutant colorectal cancers. So we hope to use this approach to apply to find treatment for school patients. So how do we do that? We always start with the patient, right? So we obtain the tumor tissues, we can dissociate the tumor tissues, and this can be allowed to establish cancer cell lines. This we can adopt them to grow in a plastic dishes, which allow us to do the modification to the genetic screen I told you about earlier. And we can do this in one gene at a time in one cells and across all the genes. Of course, you can do many, many thousand of the genes. When we modify the gene function, we can actually barcode those cells. So we can track the tumor cells so that we can see how the cells respond to the modification. Now, if we target the genes that for which the drugs are already available, we should be able to identify a new use of existing drugs to treat those tumors in schools. Of course, you can also apply the same settings, use the cancer cell line to do the drug screen that I mentioned earlier. However, as you know, we only have a subset of genes can be targeted by the existing drugs. And this is what genetic screen become very beneficial, because if we can extend this to serve the entire genome in the cancer cells, and this will allow us to identify a novel drug target. Next, please. that will follow up the drug discovery, because maybe these drugs targeted will be a better sort of to be treated to target these cancer cells. So while cancer cell is a workforce, because we can culture them, modify them, treat the drugs, they are only a 2D, two-dimensional culture system, right? And as you know, the tumor is a three-dimensional structure. This is why we can also try to establish a second model, such as referred as cancer mini organs, if you will. These are three-dimensional structure, consists of cancer cell, they're self-organizing, and we can actually apply them in the tissue culture condition as well. Because these are more complex system, we cannot amend it for genetic modification, but we can provide the drug compound for the screening. Now, finally, the most advanced and complex model system is the tumor transplant model. This we do in collaboration with Dr. Moore Park and McGill, who's the expert doing this. We take in the tumor tissues from the patients, we can actually dissect into small pieces and can transplant into animal models. And we can grow this tumor in those animal settings. And this will allow us to actually test whether or not the drugs we identify in the tissue culture condition can also be effective to treat those tumors growing in this live animal. This is important because not all the drugs that works in tissue culture condition will work in live animal, right? Because the way the tumors grow have very different architecture than we grow in the tissue culture conditions. Also, how drugs penetration to the tumor is very different as well. So by using those models, the drugs we found safe in animal setting, effective to support tumor growth, will be hopefully can lead to clinical trials, because we all know that obviously animal is not a human, so we have to validate in patients. And the ultimate goal is to identify effective treatment for school patients. And I just want to give you two examples. One of the recent example is a work that co-led by Dr. Wills and myself. And this had led to identification a new class of drugs that are currently approved for the treatment of breast cancer, including palbociclib. And this is effective, potentially effective to treat school patients, as well as SMARCA4 mutant cancers. And this is being tested as one arm of existing clinical trial, Tachdjian trials in Canada. The last example, most recent example, we're quite excited about. This is a joint study with Dr. Yeming Wan for UBC. Of course, very close collaboration with Dr. Will Foulkes and Dave Huntsman for UBC. In this study, we uncovered a very interesting addition of a SMARCA4 deficient cancers, including school and lung cancers. And this addition can actually be targeted by using a natural dietary supplementation. And we actually show that if we feed the mice, I told you earlier, that grow in the human tumor, this dietary supplementation is sufficient to slow down the tumor growth. When in combined with cisplatin, which is commonly used to treat school patients, we see a strong, remarkable tumor suppressing effect. And this is most response we ever seen in any target therapy we have seen in our models. So we're really excited about this new finding, and we hope this will lead to a clinical study to help to treat the patients. So finally, I just want to coming back to this really last point is, of course, I cannot put everybody contributed to work on the slides, but included patients, families, patient advocate, clinicians, and everybody in my lab coordination. They work very hard with the same goal, right? We try to identify effective treatments. And I hope to convince you that this is really important for this registry, because we need to access the tumor tissues. Everything we do is starting from the tumor tissue. So with that, thank you for attention, and thank you for being here.
Thank you, Sid. That was an outstanding short summary of really exciting work, and I think will really change things for the future of patients for the benefit. And I'd like to thank all the speakers really for a tour de force tour, of the latest aspects of this disease. I hope all of you have learned something from this. I certainly have. I think there may be some questions. There may not be. Everybody may be stunned into silence. but you can certainly say with regard to Sid's work, you heard it first here, because that's the first time we've talked about a natural dietary supplement as potential treatment for a devastating cancer, which is if you think about it, somewhat surprising. But anyway, we'll be able to discuss the data more fully when it's been submitted for publication. So if there are any questions, Melissa, you could maybe field them. If there aren't any questions, then we can certainly discuss things amongst ourselves. But why don't we take a question? Why don't you take the first question there?
Yeah, of course. So for Dr. Pressey, Dr. Levine would actually like to know for clarification, is HDC only for patients with no evidence of disease after chemo?
Hi, Doug. We are offering, so high-dose chemotherapy with stem cell rescue, we're offering it to all of our patients with this diagnosis, regardless of the age or stage. It's really, I think radiotherapy is where we're being a little bit more careful about only offering it to people with residual disease at the time of the second look operation. But we think that everybody should have stem cells collected, and with the intent of doing bone marrow transplant to consolidate treatment.
Great, thank you, Dr. Pressey. Alice, yes, the registry is open worldwide for anyone. You can even sign on behalf of your friend if you'd like, or you can, both of you can email me and I'm happy to take a call. Leslie,
certainly like to point out, just interrupt, that being in Quebec, being Montreal, this is all in English, but I can tell you everything's in French. So there's no problem with completing questionnaires in French. We have, in fact, there's a good point. We have one of our, I think getting to this point, getting this meeting organized has been a big focus for Melissa and to a lesser extent for me for a while. Once this is done, we're going to reach out to more groups. And I know the French group based both in Lyon and in Paris have done some tremendous work. And we'd like to make sure that all the French patients who have had small cell cancer and their relatives are aware of our registry. And as Sid said, I'll just take the moment just to say that, getting some fresh tissue is logistically challenging, but certainly not impossible. And it's really the way forward. And one of the reasons we got this grant funded from the DoD was because we agreed to make all the tissues available to anybody free of charge, except for processing costs and without restrictions, sort of material transfer agreements are required. We're just going to make them available to everybody, so that we're not trying to. We want to make sure other people can benefit from your contributions, and it isn't just a select group of people.
Leslie, I know you had your hand up, so I've allowed you to speak if you'd like to ask your question out loud, or I could read it on the chat.
Oh, thank you. I think I maybe didn't quite type properly. So regarding I'm talking about the SMARCA4 gene. Regarding the childhood rhabdoid cancers, are you finding that you're only treating females? Have you got any experience of males?
Joe, I think you can probably take that question. Yeah.
So speaking of malignant rhabdoid tumors that often have SMARCB1, but sometimes SMARCA4 mutations, whether it's atypical teratoid rhabdoid tumors, malignant rhabdoid tumor of the kidney, or soft tissue malignant rhabdoid tumors, they can be either male or female. I think that makes it, and obviously they're usually younger patients, and maybe an interesting discussion point for the group is, on the other hand, small cell carcinoma ovary obviously arises from the ovary, and in young adults, it's that age and gender aspect of it is kind of an interesting distinction from the more, what we typically think of as a rhabdoid tumor.
Yeah, the tumor specificity is one of the great mysteries of cancer genetics in general. If you think about it, why do certain inherited disorders affect only certain organs? We don't really know. The SMARCA4, the good side of it, if you like, is that the ATRTs, the teratoid tumors, are actually extremely rare. Even if you have a SMARCA4 germline variant that you inherited from one of your parents, it's extremely rare. It's probably less than 1% of all ATRTs, and the German group have published some nice work there. And just to again emphasize what Glenn was saying earlier, in a sense, these tumors are actually extremely similar. You cannot really tell them apart down the microscope. If you just had a field of these cells, they look very similar. So the mystery is, why are they so common, relatively speaking, in the ovary, and so relatively rare in the brain? And that probably relates to some of what Basile was saying about the way in which DNA is unspooled and opened. And of course, answering this question is something that will probably keep him busy for the next 30 years.
Thank you all. Taylor, you had a question. I allowed you to speak if you'd like to ask it out loud, or I can read it, whatever you prefer.
Yes, personally, I didn't have the SMARCA4 mutation, and I didn't know if that, what that even means.
Can I just ask, okay, so that's a question. We can continue some of these conversations offline, obviously, because some of them may require more information. There's two, essentially, SMARCA4 is, as Glenn was saying, is involved in almost all of these tumors. A couple are SMARCB1, as Joe was saying, for the brain tumors, but they're extremely uncommon. It's like a handful worldwide. So SMARCA4 is the main gene. The SMARCA4 can be knocked out and cause the disease in one of two different ways. Either you can inherit one copy, or it's in all of your body, all of your cells, okay, and it happens to affect the ovary, or it can just be in the ovary. So if someone did a blood test looking for the SMARCA4 mutation and it wasn't present, then probably the SMARCA4 gene was knocked out, both copies, just in the ovary. But this is something that probably we could discuss offline, because it's important to know what testing was done, who did the testing, what the results show. And that's one of the reasons, to be honest, to be part of the registry, because as part of that, we're going to collect that information. And sometimes we find stuff that, and Leora, I know, is listening. And, we have found cases when someone said they had a SMARCA4 variant that caused cancer, and we pretty clearly proved that it did not cause cancer, even though they were told it did. So it's not as simple as, oh yes, you have a variant, you have a disease. This is where the expertise comes in, and we can help you with that.
Great, thank you. So yes, Taylor, you should email us and we'll schedule a call. Gretchen, you had a question. I allowed you to speak if you'd like to ask it out loud, or I can read what you wrote in the chat.
Yes, I was just wondering if you could share with us what that dietary supplement is that's showing promise, if we were allowed to know that at this time.
Sid?
So unfortunately, I cannot share the identity at this moment because this involves quite a few groups. I had to have get permission, and these are not published or not submitted yet. But what I can say about this supplementation is actually currently being used as a recommendation for another unrelated disease. And the dose we are using, at least in animals, that estimate is definitely achievable.
I can understand that's frustrating, because you can say, well, if this is a -7, why can't we all be taking it? It's very, very important that if this is going to prove to be important, that we don't blow it by doing the wrong study. And this is where it's important for us to liaise with Joe and Amit and other people and say, look, how can we test this out in a very efficient way, a very rapid way, but in a way that other people will believe? Because if we just people start taking whatever it is, whether it's vitamin C, vitamin B2, whatever it is, which it isn't those, by the way, if you do that and then it doesn't work, then we go, oh, it's a disaster, it's fallen off the track, and that may be a mistake, So I think this will be common knowledge with it, probably this year or certainly early next year. So it won't take too long to find out, but we do need to test it out. This is research, it's lab research. It's not the same thing as trying it out in patients, and that has to be done if we really want to make a difference. So I understand that, it may be frustrating, but please hold on and you'll be the first to know.
We'll be happy to send you the publication once it's out. Kelly, I've allowed you to speak as well. If you'd like to ask your question out loud, Kelly Ballard. No, maybe not. So I'll read her question. In regard to the collection of data and tissue collection from patients, will the families be kept up to date on the progress and findings? Her daughter passed away from SCCOHT, and they've been submitting information to our registry. Thank you again. And they want to know what is going to be used with it.
Yes, I very much hope that's the point. There'll be an iterative process. Obviously, some of this depends a bit upon funding. We have to keep the thing going. After all, the registry is quite. It's not very costly, but longevity with these registries can be an issue. So we hope to be able to keep this going for as long as possible. And every year we could issue, for example, a summary report back to all families. But it will take a long time, to be honest, to gather the key data. One of the questions that people are asking us, for example, is what is my risk for small cell cancer if I have a SMARCA4 variant? It's an obvious question, and one that we really need to answer, because it informs questions that Glenn raised, such as removing the ovaries of people at risk. What age should one do this? What kind of risk would be required to make that decision? And we just don't have the data. I mean, I end up advising people based on kind of intuition and a bit of guesswork, but I don't really have hard data. And that's where gathering all the data from all the people. For example, if a young woman dies of small cell cancer and the parents are known to have one of the parents has the variant, then we can chase it out through the family and say, well, actually, the risk wasn't as high as we thought, or maybe was high. So it's important for us to make that decision to help families. So that's why we will be getting back to families, but it's important that we get the data so we're able to share meaningful data with people.
Thank you. Leanne, I've allowed you to speak. Leanne Crow, if you'd like to ask your question.
Yes, so I underwent the genetic testing and was found to have the SMARCA4 as well as a BRCA2 mutation. So I was just wondering if anyone has heard of anyone who has both of those mutations, and if research suggests that there's any correlation between the two.
I have not heard anybody with both. It will happen. The more testing you do, BRCA2 is much more common, affecting about 1 in 200 people. SMARCA4 is much, much rarer. So, it will happen occasionally. There will be someone else in the world, I'm sure, with the same combination, but they just don't know it. I think, again, offline, we could perhaps share the information just to make sure I understand exactly what the variants are. It's important to know, are they both of the same type? In terms of risk, yes, there is a connection, obviously, because they both can affect the ovary. So that's a discussion in terms of management that would have to be considered as to how one would deal with that. Obviously, BRCA2 obviously increases the risk for breast cancer, which we don't think SMARCA4 does. We've never seen anybody with a proven SMARCA4 mutation which was definitely causative of their breast cancer, whereas BRCA2 obviously is the second most important breast cancer gene. So that's a discussion again we could have later, but I don't know of anyone else with exactly the same combination of variants that you've just described.
Great. Polona asked the question earlier. Polona, I've allowed you to speak if you'd like to ask your question, or I can read it out loud, whichever you prefer. Maybe she's not here. So Polona's question was that my doctor wants to stop all therapy treatments and they don't seem to be working. Until now, she's had several different types of chemo. So she had etoposide, cisplatin, 3 surgeries, radiotherapy, immunotherapy, Nivo, IPI, and now she's currently on Nivo and abemaciclib, and they want to discontinue that because she is having lymphedema. She wanted to know if anyone would suggest any other treatments that would be helpful for her.
Amit, maybe you can comment there, sure. And then maybe Joe.
Sure, I think that this is where we probably need a lot more detail in terms of looking at both what treatments Paloma has had and what may be potentially feasible based on the sort of evidence as well as any information from profiling. So it would be probably better to have a much more detailed discussion in terms of what is feasible based on the treatments that she has had and building off some of the sort of early data that Sid and others have generated in terms of some of the sort of targeted approaches as well as immunotherapy combinations. I think immunotherapy she has had, it sounds like, but I think for a more detailed response, I think we probably need to do a deep dive in terms of the treatments as well as some of the information about the biology and profiling.
Great. So Polona, I will give you Dr. Oza's email and you can reach out to him and he's happy to help. The next question was from Luther. You are allowed to speak if you'd like to ask your question aloud.
Hi, hello. From Germany here. I wondered if there's any deeper knowledge or studies going on about the actual risk that SCOT manifests. My concrete example is my daughter is 19 and she was diagnosed with SCOT. I have the same genetic SMARCA4 mutation and I have not been diagnosed. I just wonder if there's more, is there deeper knowledge about how this
Luther, thank you very much for that personal story that's extremely relevant to the question at hand. And this is exactly one of the issues we're struggling with, which I was alluding to earlier, and why we need to gather as much information as possible from the relatives of people who have small cell cancer, not just the patients themselves, because the only way to work out what the risk for people is to test everybody in the family to find out, particularly the women, obviously, to find out who actually has the gene and who doesn't. And when you have that information in an unbiased way, in other words, if you test everybody, then you'll get an estimate of what the risk is. Now, obviously, if you test only families, in other words, two women in the same family with the same disease, it looks like everyone's at risk because by definition, you are focusing on people who have the disease. So it doesn't take much to realize that in that situation, the risk is very high. But we know that isn't the situation for most people. Okay, and so what we need to do is collect more information from people like yourselves and your daughter and any other family members. And by building these family trees and exactly working out what everyone's risk is, we can then say, okay, so by age 40, your risk of small cell cancer is N%. We think that, that at least 20–30% of women who have this disease have a germline variant. That is, they were at risk from conception or from soon after conception, and we don't know what their risk is by age 20 or by age 30, so we need to try and get that information as soon as possible to help people, and I think that's really why I'm saying enrolling in the registry is important, to keep Melissa busy, and to make sure that we collect as much information from relatives. So it's got a number of facets. It's got the collect the sample facet, which is for Sid and for Amit and for Joe and people like that, to use those samples to further the research into the mechanisms of why the disease happens. But it's got this other side, which is just as important, is to say, okay, what is my risk of developing this disease? Because that's going to inform decisions about removing ovaries, which, as Glenn was saying, you don't do lightly. I mean, you don't want to remove the ovaries of a 10-year-old if the risk is at in less than 1%. Whereas if the risk is 20% by age 15, you may say, and obviously in the case of your daughter, if we'd known she was at risk when she was 18, we would have done the surgery. I mean, without any question, but we didn't know. And that's the trouble. So we have to try to work hard on this aspect, but it can only be a collaboration. There's no way any of us can do this by ourselves. And that's true for all research. It's a collaborative process. People are on this call working together with people listening to the call to try to a common goal, essentially.
Thank you, Dr. Foulkes. The next question was from Gail. Gail, I've allowed you to speak if you'd like to ask your question out loud. Give her a minute.
I'm doing, sorry.
It's okay.
I was just wondering if with the current treatment that is being provided to these young women, have the statistics of survival improved at all in the last, say, year or two?
It's a great question. I think a very, very hard one.
Yes.
Dr. Foulkes, you're muted.
Well, I'll defer to Will, but I would say, it's, given the rarity of the disease, I think, I think that N of 1 discussion earlier is very important. We need to think about everybody individually and provide the best care possible, and give them the benefit of all the active agents that we know of that can be given tolerably. But I think as far as sort of immediate updates in the last couple of years, that's not something I would have. I may have other thoughts about that, or Amit.
So I think that's part of the importance of collecting data through registries like this, because I think one of the sort of challenges is how do we sort of interpret the data from small number of cases at different centers, even with expert centers like Joe's center or my center. The number of young women that we see is still relatively limited. And so it's really important to individualize decisions in terms of the treatment. So getting the best available treatment at the right time and with a sort of a multidisciplinary approach, I think is really very much the important thing to do. There have been a number of sort of promising reports, both related to multisystem chemotherapy, like the one that Joe reported, as well as integrating immunotherapy, but the numbers are still small. And so I think one of the sort of pleas that we have is to really get good data together through this registry as well as other sort of groups. I work with the Gynecologic Cancer Intergroup, and one of the things we're going to try and do is to get some data for rare tumor types, including small cell hypercalcemic ovarian tumors, so that we can actually have better data that we can report, and particularly looking at what are the approaches at early stages as opposed to advanced stages that actually should be sort of implemented in the right time.
So I'm mindful of us going over time, and we said an hour, and I know people have got things to do in the rest of their lives, particularly I'm sure some of the panelists have got other things planned and booked for today. So I don't want to, I don't really want to cut this short, but I think I probably ought to. And I think we can continue these conversations offline. I think you now know you've got Melissa's contact, and please contact her for further information about the registry. If you want to contact any of the individuals on this panel, I'm sure they'd be happy to field questions, directly or indirectly following this meeting. I think if you all feel this has been helpful, please let Melissa know, and we would consider doing this again, maybe with a slightly different focus, maybe in maybe a year's time or 18 months, something like that, just to tell you what we're up to, what's new. The field doesn't move incredibly rapidly, but there are changes. I think this meeting, definitely would be different if we'd had it, 2 years ago. So I think I'd like to once again thank all of you for attending. I'd like to particularly thank Amit, Sid, Joe, Glenn, Basile for their wonderful presentations, and please watch this space. And for those of you who are being treated, obviously we all wish you absolutely the best in the time ahead. So with that, I will say goodbye and thank you very much. And
just the final note.
Yeah, go ahead, Lisa.
Alice and Leanne, who just asked the question, I've copied your question and I'll have one of the panelists email you an answer, right? So just so you know you weren't forgotten. And like Dr. Foulkes said, my email is in the chat. If any of you have any other questions for a panelist or would like to join the registry or learn more, please email us. Okay.
And the recording will be available. Can we put it on the website, do you think?
Yes, it'll be available on our website and on Maren Peterson's website. And I believe Liz Oppo will be sharing it as well.
So you're all able to rewatch it again and pick up on things that you missed. All right. Well, thank you very much to everybody again.